Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am so happy that today we are going to hear from Dr. Robert Aaronson. He is with our TMC Pulmonary Associates, and he's going to be talking about a topic that I don't think we have covered here at TMC for Seniors, which is why I'm really happy that we've got it. You're going to be talking about Breathe Easy, Managing COPD. Welcome, Dr. Aaronson. How are you today?
Thank you. I'm terrific. I'm glad to be here.
Good. So I've gone ahead, I've put up your PowerPoint for you. I know you've got a lot of information to cover. You do have an at-home audience that's watching along with an in-person audience. Once we're all done, I'll ask any questions that come in from home. If you've got a question for Dr. Aaronson, please put it in the chat and then we'll get those answered for you at the end. And I'll turn it over to you, Dr. Aaronson.
Terrific. All right, well, welcome and thank you everyone for being here. I'm delighted to be here. So I have prepared some slides, but I think perhaps the more important part of today's session, I hope, will be entertaining questions both for those on videos, on virtual, and those of you who are here. I don't want to get bogged down into too many pieces of minutia of COPD evaluation, the particulars of medications. Although I'm happy to talk about any of those things in the question and answer, let me sort of give an overview of what COPD is, how we diagnose it, what the usual treatment rationale and approach and reasons for treatment, and how we treat the disease, and then hopefully we'll have some time to talk about more about this. If at any time, for those of you who I can see in the audience, if for some reason you can't hear me, or if something I say is painfully confusing, I promise you it's probably painfully confusing to other people as well, because perhaps I misspoke. So feel free to raise your hand and let me know. Okay, let's begin. So first, let me start with some quick facts about COPD. COPD stands for chronic obstructive pulmonary disease. In fact, this is chronic obstructive lung disease. But the reason we don't call it that is the acronym would be COLD or cold, and we'd all be confused, right? So COPD it is. And I say this not to be scary, but to make a point. COPD is currently the fourth leading attributable cause of death in the United States. It accounts for nearly 160,000 deaths per year. I say that not to be scary, but to, one, highlight the importance of the disease, but as well to highlight the fact that that can be improved. And there are great opportunities to make a big difference, both on a population basis as well as for any individual person. More than 16 million people have been diagnosed with COPD. Estimated, however, that millions have COPD and don't know it. And indeed, that very well is part of the reason why there's often higher attributable death to COPD than there should be, because often people are treated appropriately because they don't know they have it or suspect they have it. But of course, if you don't ask, don't tell. If you don't look, you don't find it. And as long as you don't find it, you maybe don't have to worry about it. But of course, it's best to know and to deal with it appropriately. And a leading cause of disability as well. I've already mentioned that awareness of COPD is not all that it should be, and up to a quarter of adults in the U.S. actually haven't heard of COPD. Roughly 3 out of 10 people with COPD symptoms go undiagnosed and untreated. So what is COPD? Well, first and foremost, it's an important serious lung disease. And what happens is that as changes occur within the lung, there's less airflow in and out of the lungs, and that occurs for a variety of reasons. The airways and air sacs become less elastic, so they spring back less, and so pushes the air out less well, and air can get stuck within the lungs. The walls between those air sacs or alveoli become destroyed, and that's sort of a hallmark of emphysema, kind of like moth-eaten lungs, right? And so that leads to problems. The airways themselves can become thickened, and we'll talk in a moment about emphysema versus sort of a chronic bronchitis pattern of COPD. But those airways can become thickened and can produce more mucus. They can become narrowed by inflammation, and that mucus can get in the way of breathing and cause worsened symptoms. So with all of this left untreated, people with COPD gradually can lose their stamina and their ability to perform daily activities and can be at increased risk for infections and respiratory failure and other things we certainly want to prevent. I mentioned already that COPD is often sort of described in two different types, and in truth, most people aren't one or the other, but have a little bit of both. But certainly there are some people at one end of the spectrum of chronic bronchitis, and some people more at the other end of the spectrum at emphysema. So emphysema occurs from those damaged alveoli, those damaged air sacs. And with that, the lungs lose their elasticity so that they actually become bigger. The lungs are bigger, but they're less able to move air in and out. And with that, people become more short of breath, especially when you're doing things, especially when you're using muscles of your shoulders and back. We all normally breathe with our diaphragms, that muscle that separates our abdomen from our chest. It's a muscle that comes up and pulls down. When it pulls down, when we take a deep breath, we're actually pulling that muscle down, and that expands the volume of our chest. So our chest, the volume of our chest with our lungs gets bigger, and we pull air in, and then we breathe out, and we let that air out as the diaphragm comes back up. But when we have emphysema, when we've destroyed those alveoli, the lungs get bigger. And even though they're bigger, the diaphragms are flattened, so they can't pull down. And we do more of our breathing with our shoulders, with the muscles between our ribs, with our neck muscles. And so what happens is we get more short of breath when we're doing things. Some people might notice even showering, washing our hair can make us more and more short of breath. And indeed, as we'll talk about in a few minutes when we talk about pulmonary rehabilitation, exercise that can help the symptoms of COPD, interestingly and not really intuitively, it turns out that not only exercise like walking and building stamina, but building the shoulder and back and chest muscles can really help COPD symptoms. On the other end of that spectrum is chronic bronchitis. Chronic bronchitis is inflammation of the airways, where the airways become swollen, so the caliber, the lumen, the opening of the airways becomes smaller, and those inflamed airways make mucus. So instead of the airway being a big tube, now it's a smaller tube, and that tube is partially filled with mucus. And as you can imagine, that can make breathing that much more difficult. And much like if you were sitting quietly breathing through a straw, it might feel okay, but if you tried to get up and walk, or if you became anxious and you were breathing through that straw, all of a sudden breathing wouldn't feel so good. And so that's a problem with chronic bronchitis. And some people have, again, mostly chronic bronchitis, some people have mostly emphysema, but most people with COPD have a little bit of both, where they have all of the symptoms I've described in some varying amount or proportion. And here you can see it graphically.
Where does interstitial lung disease come in?
Interstitial lung disease, a completely different problem. And so perhaps in the question and answer we can talk about that. Yep, a different issue. But here you can see just an image of those two things. So bronchitis, itis means inflammation. Bronchitis means inflammation of the bronchial tree, the airways. Chronic bronchitis means it's chronically there, as opposed to like when you get a cold, and that's an acute bronchitis. But this is chronic bronchitis, and as you can see on the left, that airway has become thickened and there's more mucus. But on the right, we see emphysema, where the airways, the alveoli become destroyed. So you can see the two examples on the left and the right there, that the alveolar sacs are damaged. Okay.
Dr. Aaronson, I'm sorry, I had a question come in. I just wanted to ask, where is hyperinflation on the scale?
I'm sorry, where's hyperinflation?
On this scale.
Well, as I said, when people develop COPD, I'm not sure in terms of referring to a scale, we can grade the severity of hyperinflation, but when people develop COPD, they usually develop at least some degree of hyperinflation, meaning the lungs get bigger. And that happens for the reasons I mentioned, where there's loss of elasticity. When we do a sternotomy, if we open up someone's breastplate and the ribs pop open, and so holding, we put them back together. When you wire them back together, like in heart surgery, you actually have to push them back together because the ribs want to spring open like this. And the lungs actually want to collapse down because they're very elastic. And it's actually that when the chest is closed, that suction that's created by the chest that keeps the lungs open. But when you lose that elasticity of the lungs because of emphysema, then the lungs get bigger and bigger within the chest. And that causes all the problems we were discussing before.
Thank you.
And so let's now talk about what the common signs and symptoms of COPD are. So, and any one person may have all of these, or indeed sometimes people have significant emphysema, but may have none of these. But most people have some combination of coughing, and sometimes people, I think, wrongly sort of just to say, oh, I've got a chronic, I'm a smoker, I have, a smoker's cough. Well, yes, smoking can cause irritation, can cause coughing, but part and parcel of what's happening is you're damaging your lungs and you may be developing chronic bronchitis or other problems that lead to cough with COPD. Shortness of breath. And usually if there's no other symptom, that's the one symptom people experience initially when you're doing something because you're stressing the system, right? But then later over time, as you do less, or even if you're just sitting around, you can get short of breath. So as the disease progresses, symptoms can progress, although things can intervene. We can do things to improve that, right? We can use medications, we can do pulmonary rehab, things we're going to talk about in a few moments. The inability to breathe easily. And that's a strange thing, but if I were to ask everyone, here now, for the next minute or so, I want you to pay attention to breathing normally. I think everyone would start to recognize that within a very short time, it starts feeling uncomfortable to breathe, right? We normally, our heart beats without our paying attention to it, usually. And we breathe, usually, without paying attention to it. And indeed, as soon as we start focusing on our breathing feels wrong. Part of the problem, of course, is people who truly do have lung disease. If you have COPD or other lung diseases, then breathing might not feel good frequently, and that leads people then to be more aware of their breathing and focus on their breathing, and that sense of not breathing right can actually compound the problem because people become more and more concerned about not breathing, feeling normal. So sometimes we really work with people to try to, in a sense, we want you to be attuned to your lungs, to be aware of your breathing, but to not overly focus on how you're feeling second to second, because for some people that actually is detrimental. Excess mucus production, we've kind of addressed this already, and you could recognize how that could be a problem. And of course, wheezing. So the more chronic bronchitis you have, the more wheezing you have, almost as if you had, and likewise, asthma is also a very different disease, but very similar to COPD, but different. But chronic bronchitis, like asthma, often is associated with wheezing. Pure emphysema is usually not associated with wheezing, but again, most people are somewhere in between and have a little bit of both. I can't come here and talk with you without talking about smoking, and of course, it's not going to be a surprise to anyone that smoking is not a good thing, and there's lots of reasons why we shouldn't smoke. But to point out that smoking is the number one reason why people develop COPD. To be clear, not everyone who has COPD has smoked. Worldwide, many people develop COPD from inhaling burning biomass for other reasons. If you live in a hut or a yurt and you cook over an open flame with wood and coal and you're breathing all of that in, it can be doing much the same damage as cigarettes. But there are other industrial exposures that people can have that can lead to COPD. And as you can see there at that third point, as many as 1 in 4 people who have COPD have never smoked. Long-term exposure to lung irritants, we've talked about a whole variety of chemicals, dust, fumes, and it has to do with the particulars of what that particulate matter is, how long you're exposed, how intense the exposure is, and sometimes how long ago the exposure is, because damage sometimes takes time. Indeed, people often say, I see patients all the time who we're diagnosing with COPD, and they say, how can I have COPD now? I quit smoking 10 or 15 or 20 or 30 years ago. And the thing I would remind you is, at least in a vague sense, smoking ages your lungs faster. So that, as I've gotten older, I've come to realize that When I was about 25, I was about as good as I can be in many things. And as we get older, there is a decrement, a deterioration somewhat. Although, quite frankly, a healthy 70, 75, 80-year-old actually usually isn't bothered by breathing symptoms. But the difference is if you've smoked from the time you were 20 to you were 50, even if you feel great, your 50-year-old lungs are really kind of like 75 or 80-year-old lungs. And so when you were 10 or 15 or 20 years later, now you have sort of, at least analogously, the lungs of a 95-year-old. And sort of at least conceptually makes sense to say that, yes, you quit smoking before, but it's the cumulative damage that's led to the development of symptomatic COPD now. Okay. And just to finish off, there is a genetic condition, something called alpha-1 antitrypsin deficiency, which can be inherited. It's you can get it from your genetics, from your parents, and that can cause rapid destruction of the lungs. Although I will point out, while people with alpha-1 antitrypsin who don't smoke can develop significant lung disease, it is dramatically more likely to develop and dramatically more likely to progress if you smoke. There is a medication, a replacement of that enzyme that these individuals lack that can be obtained, and we have many patients who we send for weekly injections of this, infusions. Okay, who's at higher risk for COPD? Well, of course, first and foremost, as we talked about, people who smoke, but other things. So it turns out that women are slightly more likely, although that percentage-wise is enough to protect anyone. So both men and women are certainly at risk for COPD. There at least appears to be a higher rate in rural areas than in urban areas, which is a little counterintuitive, right? I think many of us might think, oh, we live in cities and there's pollution, but it turns out that actually urban areas a little bit more, maybe because of exposure to dust and chemicals, but we don't really know. And there's at least some suggestion of certain disparities within different racial and ethnic groups, and those numbers are listed there, as you can see. In part, that has to do with smoking. In part, it likely has to do with other environmental factors, although it's possible that there's some genetic factors involved as well. All that has not been fully clarified. Okay, how do we diagnose COPD? Well, first let me say that COPD is chronic obstructive lung disease. So in fact, at least officially, you don't have COPD unless there's objective evidence for obstruction, and that is something we determine by doing a pulmonary function test or a simple spirometry, which is a form of pulmonary function testing. But I will say that people can have symptomatic emphysema or symptomatic chronic bronchitis, even in the absence of obstruction. So even though that may not officially fall into the, at least in the United States, definition of COPD, it's lung disease that's causing symptoms for which interventions can be helpful. But in either event, it's symptoms, it's history, it's examination, it's spirometry, which is a simple test that can be performed in any doctor's or office. And there are more involved pulmonary function testing we can do in our office, in the hospital, and elsewhere, but actually not necessary, but can be helpful. Sometimes chest imaging can help clarify things. Chest x-rays, which can show that hyperinflation, those big lungs, and those flattened diaphragms we talked about. CAT scans of the chest, which give a better picture into the tissues and airways and other structures of the chest. So we could actually sometimes see on a macroscopic level, on a big level, emphysema, or even changes of chronic bronchitis. And sometimes your doctor might ask for an arterial blood gas test. If any of you have had that, you would remember it, because it does pinch for a second. It's not horrible, but it's a needle that goes into an artery, usually the radial artery, on the thumb side of your wrist. And a quick little moment where we take some blood, just pinches a second, and it tells us actually about the oxygen and the carbon dioxide in your blood. Okay. As we talked about already, sometimes the biggest barrier to treating COPD is not knowing it's there. And sometimes the biggest barrier to knowing it's there is patients not willing to either recognize or acknowledge their symptoms or to seek help for their symptoms. Of course, part of my pitch today is encourage people who may be wondering to perhaps come and find out, because there are things we can do. Likewise, sometimes patients come to their doctor and are perhaps less than fully forthcoming about their risks. Sometimes people don't want to be chastised, and of course, chastising, patients, does no good to anyone. But sometimes people are fearful of being chastised for smoking or for other behaviors. And so, being honest with your physicians, being honest with yourself, and seeking help are certainly good ideas. So I've kind of touched on what spirometry is. It's quick, it's simple, and it tells us a little bit about the function of your lungs. It can help us know whether there's obstruction. It can help us know whether your lungs are acting as if they're shrunken or have restriction, a whole different set of lung disorders. And of course, there are many things that can cause shortness of breath or coughing and other breathing symptoms, and COPD is an important cause for those, but we always want to make sure that we're questioning what really is this, and we apply all of the diagnostic tools that I mentioned to you already. So we've made a diagnosis of COPD, and who cares? Well, we care because we can do something about it, and we can not only can we do something about it, but it's valuable, right? Just because we can do something, it's not the reason to do it. We should only do it if it's going to help, if it's going to make you live better or live longer, or ideally both, right? And so we treat COPD to reduce symptoms, to improve exercise tolerance, to improve general health status. And by the way, of course, if you're not breathing well and you don't do anything, not only is your lung function not great, but a lot of other problems develop. The one thing that doing nothing gets us really, really good at, of course, is doing nothing. And it's valuable, especially as we all get older, to remain active. We also want to reduce risk, right? Risk of deterioration, risk of exacerbations, risks of death. And there are things that we can do to help with all of that. So this slide just talks in a very general fashion about how do we treat COPD, and of course, medications are an important part of that, but certainly are not everything. Pulmonary rehabilitation, I'll talk a little bit about that in a moment, can play an important role. But lifestyle changes, and I think that should probably be first on the list, and that includes, of course, not smoking, and we'll talk about other lifestyle changes that can be done. Oxygen therapy when appropriate, and we'll come back to that. And then in some patients, there are interventions, meaning invasive things that can be done to help, and I will just say right off that that's the minority, the small minority of patients with COPD. At the very extreme, appropriate patients might benefit from lung transplantation. Close to that extreme are surgeries to remove parts of damaged lungs to improve the functioning of the good lung. And nowadays, we can actually do that latter procedure where instead of removing those bad parts of the lung, which is often referred to as bulectomy, or in some cases, lung volume reduction surgery, those things can now be done with a bronchoscope, meaning with a scope that goes into your lungs and the placement of small little valves that sort of let air out of these dilated, over-distended areas, but don't let lungs back in, so they can effectively get rid of those bad parts of the lung. And then there are a variety of other interventions that we can talk about in the question and answer period. But let's move for the moment to talk about lifestyle, right? And of course, quit smoking. And I encourage everyone to quit smoking. And I recognize that it is really, really, really hard, right? Patients come to me all the time and say, I want to quit smoking. And I tell them, it doesn't matter if you want to quit smoking. You just need to decide you're going to quit smoking. I want to not eat too much chocolate, or we all do these things, right? And of course, and I say this not to be teasing or flippant about it, but we recognize that really it's a hard thing. But I can tell you I've done this long enough that I have had literally thousands of patients who quit smoking. I am saddened by how many of my patients who quit smoking the day they found out they had lung cancer. And all of a sudden they started to quit smoking today. And you know what? It actually turns out that it's a good thing anyway, because even patients who are diagnosed today with lung cancer, if they quit smoking, their life expectancy is longer, okay? And of course, many patients with lung cancer today we cure. If they keep smoking, the chance of getting more lung cancer, again, is that much higher. So quit smoking. And if you can't quit smoking, cut down dramatically, right? Avoid pollutants, right? Don't spend your time over open campfires and things that will cause more irritation, potentially more damage. Identify COPD, treat it, right? Avoid illness. Silly thing to say, but it's really true, right? I mean, stay away from adorable kids with mucus running out of their nose, during flu season. Wash your hands a lot, right? Do all the precautions you should do. Vaccinations, right? So pneumococcal vaccination, people refer to as the pneumonia shot, is really a vaccine against Streptococcus pneumoniae, which is the most common cause of deadly community-acquired bacterial pneumonia, and it's something that we have vaccinations to help prevent, right? Influenza vaccines. And if you're over 65, the high-dose influenza vaccine. RSV vaccines, recommended for everyone over 60 or even younger if you have lung disease or heart disease or other important diseases. Obviously, COVID vaccines, other vaccines, all appropriate vaccines to try to prevent infection. So stay current on your vaccines and support, getting support with family, friends who can help you with your medications, who can help just with encouragement, with exercise, and with, because I promise you, if your lungs are your weakest link and you start babying your lungs and you start babying yourself, then the rest of you gets out of shape. And so many patients with COPD are profoundly limited, but they're limited far beyond how they should be limited based on their lung disease. They're limited because they've gotten rotten out of shape, because they've stopped doing things. And so, of course, it's not to go from nothing to running a marathon, but it's to start the process, right? Every day to do a little bit more and to work towards that. Okay, I'm going to talk now about medications. And as you will see in a moment, I'm going to show you a chart and pretty pictures of lots of medications. It can be dizzying. And of course, the goal here is not to memorize all those or to tell you which particular puffer is the end all and be all, because the truth is none of them are individually. But I want to give you an idea, at least the current guidelines and what we should do. And what's recognized is the more severe your lung disease is, based on spirometry, likely the more severe your impairment, the more severe your symptoms, the more likely you are to have exacerbations, attacks of COPD, to be hospitalized, etc. But it turns out that schema is actually very imperfect. That looking at that one number alone doesn't really help us correctly determine how best to treat you to prevent symptoms and to prevent worsening. And so it turns out that this structure does. And it's a little confusing, but let me just share with you. You can see at the top left, it says 2 or more exacerbations or a hospitalization. Now, all this has to do with the past year. And so if in the past year, you've had 2 exacerbations where someone gave you steroids, had to run to the emergency room for care because of your COPD, or you've had to be hospitalized with COPD, pneumonia, complications, then that puts you in that top group. Or if you've had 1 exacerbation or fewer, puts you in that bottom group. And then you could see on the x-axis, if you will, on the bottom, it says, very confusing, MMRC 0 to 1, CAT less than 10, or higher on the other side. Let me just simplify that. If you, when walking, are more short of breath and more limited than your peers doing normal activities, then you are on the right side there. You're at that MMRC more than 2 and CAT more than 10, okay? And so bottom line is if you're more impaired than your average peers, you're going to be on the right side. If you've had lots of exacerbations, right, 2 or more, or a hospitalization, you're on the top. And so now, understanding that, these are the recommended therapies. So if you're at the very bottom left there, where it says Group A bronchodilator, if you've had 1 or 0 exacerbations, and you're not more limited, at least in an obvious way, than folks who don't seem to have lung disease, then any old bronchodilator, and I'm going to show you a picture with lots and lots of them, is recommended. Meaning anything's good enough. And for most people, that would mean an albuterol inhaler. And albuterol comes in different flavors, if you will. ProAir, Ventolin, Proventil, just means who makes it, or just albuterol HFA, generic. They're all the same, and they're all equally good. If you like one more than the other, that's great, and use it, but they're really the same. And then there's something called levalbuterol, which is almost the same and a lot more expensive, maybe a little bit more side effects, a little fewer side effects. But most people tolerate these medicines fine. If you haven't needed hospitalization or multiple exacerbations, then a LABA-LAMA. That's two different long-acting bronchodilators, long-acting beta agonist and long-acting antimuscarinic agent. And so a combination of those two, and you can take both separately, but now they make them into one inhaler, and there are a bunch like that. I'm going to show that to you in a moment. And then if you're on the top, because you've been hospitalized in the past year, or you've had 2 or more exacerbations, then you should definitely be on a LABA-LAMA, but probably should be on a LABA-LAMA, and you see at the bottom, ICS with an inhaled corticosteroid also, an inhaled steroid to help with inflammation. And on this graphic, for those of you that can read tiny print, it says if blood eosinophils are more than 300. And so in some people, if there's evidence for sort of allergy and kind of asthma-like kind of changes, well then definitely adding an inhaled steroid to that regimen. And again, these could be 3 different inhalers, but in fact, one can put them all together and is better. Sometimes because of cost, what's covered on your particular insurance, it may be 2 different ones to get those 3 medicines. And we try to, but ideally, the right medicine is the one that's, the right particular medicine is the one that's getting you the kinds of medication you need in a way that you can afford and in a manner that works for you. Because some people do well with puffers, some people have a hard time coordinating it because of arthritis or other issues. So it's finding the right thing, okay? And there are many particulars that go into that. So here you can see lots of inhalers, and it's pretty darn confusing, okay? And this isn't everything, it's a lot of them. And let me just share with you that short-acting bronchodilators, like if you're in that group A, then probably just a short-acting bronchodilator. And all of these are formulations of albuterol, or this other thing to the right called Zopinex, which is levalbuterol, which is sort of a subtype of albuterol that works maybe a tiny bit better and maybe a tiny less side effects, but a whole lot more expensive. But for some people, it can be worth that difference, okay? But those are the short-acting bronchodilators. There's also, you can see here, down here, the short-acting muscarinic agents, Atrovent or ipratropium is the generic name, and that's also a short-acting bronchodilator. So those are short-acting bronchodilators. Albuterol works quicker, so in general, we use albuterol kind of as our reliever medicine, or some people refer to it as a rescue medicine, okay? We talked about LAMAs and LABA, and so here I've highlighted the LAMAs, and they, increased by Riva, Tudorza. These are all brand names. Yupelri is a nebulized version, and LABAs, which are long-acting beta agonists. They're kind of like long-acting albuterol, so they take longer to work, but they last longer in general. And so there they have, nebulized versions, Brovana, Performance, or they have others like Ceravent, Traverity, and these are all brand names, right? So I'm sharing these with you, and usually we try to not talk about brand names, but I know these are the things you all, know, and so I want to be sure everyone understands.
So are you saying the nebulizer with the albuterol is longer lasting?
No. So, thank you for bringing it up. So let's talk about that. So let me just share that in general, there's nothing wrong with using a nebulizer, but for most people, there's nothing necessarily right or better with using a nebulizer. For some people, coordinating a puffer, either because of arthritis or coordination, or some people are just so short of breath they can't take a good deep breath in to really get the medication in. For some people, using puffers, but nowadays we also have devices that have powders, which are much easier to use. But for some people, they prefer, for whatever the reason, using a nebulizer. That's okay. But I will tell you that for the vast majority of people in COPD and in asthma, where these similar medications are used, there's been many studies that have shown that handheld agents are equally effective and sometimes even more effective than nebulized use. Now here's the kicker. When you use a nebulizer, like if you use albuterol in a nebulizer, it takes 10 or 15 minutes before it starts to work. But guess what? The nebulizer is keeping you busy for 10 or 15 minutes before it really seems to be helping you. And so by the time you're done, you feel a lot better. If you use a puffer, 1, 2, you puffed, it takes a few seconds. And that wait of 10 or 15 minutes sometimes feels interminable, right? But in truth, it works if used correctly, just as quickly. So it works as quickly and lasts just as long. Okay, and as I said, there are combination agents, and you can see here on the bottom highlighted some of those combination agents. I'll just mention those brand names. There's Enoro, there's Bevespi, there's Stialto, and again, these are combinations of both. So in both Group B and Group E, that top group, and I'll show that to you again in a moment, a LABA/LAMA is recommended at least. Okay, and then finally, as I said, in some patients, those who've been recently hospitalized, who have multiple exacerbations, and especially those people who fit in that group and have elevated eosinophils in their blood, that's a type of white blood cell, being on something that has all three, either a single agent ideally, or some combination of agents to have all three. And so here's two examples, and this is Trelegy and Breztri are the two agents that are currently available on the market that include all three, and there will be more. Right? This table is going to change quickly. Okay, so you can see there's lots of different things. I didn't touch on all of them, but I, again, just bring this slide back to remind everyone so that sometimes if you have friends, if you're on medication for COPD or friends who are on medication for COPD and you're not on exactly the same thing, I want to encourage you to recognize that it's not that their doctor or your doctor is necessarily better or smarter or cares about them or you more. It's that there are multiple choices, and the right choice is based on a variety of factors: what's right for you, what's affordable to you, what's obtainable to you, what works well for you, and what you find to be most helpful. Okay. Let's shift gears now. And again, in the question and answer, we'll have time for questions about particular medications. What is pulmonary rehab? So it's where there is a structured program that teaches you, in part, how to better manage your COPD and avoid things that make it worse, and also teaches you strategies for breathing and handling difficulties with your breathing, and includes an important component of exercise to improve your endurance and to improve your muscle strength. And as we've talked about already, a lot of that is, yes, walking and building your stamina, but also actually helping work your neck muscles, your back muscles, your shoulder muscles, because people with COPD do more breathing with what we call the accessory muscles of breathing rather than their diaphragms. Okay. Physical therapists can talk about energy conserving techniques, proper breathing techniques. Many of you have heard about, smelling the roses, breathing in slowly through your nose and blow out the candle, right? So slow, deep breath through your nose, blowing out through pursed lips, which can help open up the airways and decrease obstruction. Also, it's a forum for people to manage the stress, that comes along with having lung disease, right? I remember I used to live in San Francisco, and I got a taste of what it is to have the world under your feet shake, where we all assume the ground below us is stable, and that feeling of uncertainty and disquieting when the ground below you is unstable. And I can only imagine that's what patients with lung disease feel, right? I mean, we expect to breathe and to not even think about our breathing, and when it doesn't feel good, when we're limited, it can be very disheartening, and it can lead to anxiety and depression. And pulmonary rehab can help and can be also a conduit to help for those things as well. So what does pulmonary rehab do other than the things I've said? Well, it's actually been shown to decrease symptoms, to improve lung-related quality of life, and actually in some studies it's actually been shown to improve survival. Patients who have exacerbations of COPD and who undergo pulmonary rehabilitation within a few months actually been shown in some studies to live longer, right? And so there's great benefit to pulmonary rehab. It is paid for by Medicare. There's a one-time lifetime benefit for it. So you want to get the most out of it when you go. But there's also the opportunity for people to do continuation programs in pulmonary rehab at pulmonary rehab centers. And in today's world, there's online pulmonary rehab. There's in-home options for pulmonary rehab. And so these are all things that can be investigated as appropriate to different people. Okay, so let's come back to the treatment. So we've talked about medications. We've talked about pulmonary rehab, which, by the way, is I think usually 5 or 6 weeks, about 3 times a week. Very, very good programs. We have we actually do not have a program here at TMC at St. Joseph's Hospital on the east side, at least on the east side of Tucson. One of my partners years ago started that program. And they do a fine job there. I believe Northwest on the west side of town has pulmonary rehab, and elsewhere within southern Arizona. Lifestyle changes we've talked about. Oxygen, let me just briefly say, we live on oxygen. And if anyone doubts that, please, hold your breath for the next 15 minutes, and we'll talk about that afterwards, right? I mean, we need it. We live on oxygen and the energy we get from food. We can eat and store food. Some of us, store it more than we should, right? But because we can store food, but we can't store oxygen, which is why we need to have normal oxygen on a continuous basis, right? If our oxygen is low, we know we benefit from being on oxygen to keep it normal. Once oxygen is normal, more oxygen doesn't make us better, okay? Much like once we've eaten enough food, eating more food doesn't make us healthier. But if you qualify for oxygen therapy, then it's something that we would recommend. And I want to point out that sometimes oxygen therapy makes people feel better. And that's good. I mean, we're always happy when people feel better for whatever reason, but that's actually not the reason we give people oxygen. We give people oxygen because we know that if you're low on oxygen, you don't live as long or live as well without it, okay? And once we give you enough oxygen to make your oxygen normal, then that's good. But recognize that what's necessary when you're sitting around maybe less than you need when you're walking, when you're stressing the system, maybe less than you need when you're sleeping, when our breathing tends to get shallower. And so these numbers may change. Okay. And then I kind of touched a little bit about surgery, and let me move on from that. Let me just share that there are many, I know, those of you who have access to the internet, you just Google COPD, you'll find it. If you AI ask questions about COPD, you'll find all sorts of references to go to. I just want to point out that the Breathe Better program, which is part of the National Institute of Health, it has great information and great resources. You can actually, click and ask for, papers and other resources to be sent to you. You can download them online. Also the NIH, COPD.NIH. If anyone is interested in these things, I mean, they're easily found, but if you want to take a photograph of that page, you're welcome to as well. Okay. So anyway, I think that leaves good. I was hoping to leave about 20 minutes for questions, so I thank you all. And yes, there's a question in the back. Oh, wait a minute.
Start with online questions.
We'll start with online questions. I promise we'll get back to you.
Yeah.
We'll get back to you, I promise.
So thank you so much, Dr. Aaronson. I do have some questions that have come in that I'd like to ask. One is, do we know about the impact of vaping with COPD risk?
Not as much as we should. I will tell you, first of all, that we know that vaping is not without potential risk. Right? There is this phenomenon, the acronym of which is EVALI, or electronic cigarette vaping associated acute lung injury, that can cause devastating lung disease. People come in, often with severe respiratory failure, required to go on life support. We've had patients die from EVALI. It appears to happen, most in people who are smoking flavored marijuana, THC extracts, but can happen in anyone. People smoking nicotine, vaping nicotine. We also know that the different vaping devices are not standardized, they're not FDA regulated, and so sometimes they come in different temperatures, and so the vape that goes into your lungs can sometimes be very, very hot, can cause burns. There's formaldehyde, there's other toxins, and I think we have every reason to believe that it's probably not good for you. I'm glad you didn't ask me the question that I guess I'm going to pose right now, which is it better to smoke or to vape? And I'm really, hard pressed to answer that question. I would just say that I'm always delighted when anyone's not smoking, and at least I hope when people are vaping, it's an opportunity to sort of cut down on the, the vaping nicotine, to cut down on the concentrations of nicotine, because you can do that. You can still vape the same amount, but lower the concentration. It's a way to wean off.
Great, thank you. I had another question come in and ask about Trilogy and COPD. If it's not helping, and from what I can see, is there Trilogy and Trilogy? So I'm not certain which
Sure. So let me address both. So the Trilogy device is the name of a gadget, a ventilator that's, I think, made by Peter Bennett. It's a ventilator. And it is what we refer to as, can be used as a non-invasive ventilator. And I didn't talk about non-invasive ventilation chronically or acute. We didn't talk about acute, the treatment of acute exacerbations of COPD at all. But for some people who have, and usually people who have very severe COPD, very severe emphysema and COPD, where they have very decreased lung function, or sometimes patients who have perhaps not so severe, but severe and are very heavy, and so have sort of this overlap between significant, obesity and COPD, where just the work of breathing gets very hard, and those people can have problems with the carbon dioxide in their body builds up. And please remember, we are not trees. Trees, of course, take in carbon dioxide to make oxygen. We do the opposite, right? We take in oxygen, and carbon dioxide is an important waste product. And sometimes people can develop problems, especially with severe COPD and problems, as I mentioned, where carbon dioxide builds up. And when carbon dioxide builds up, oxygen falls, and the person is at increased risk for developing progressive respiratory failure and death. And we know in patients such as that actually using a ventilator at night, and that's most conveniently used at night when you otherwise would be asleep, so you can be asleep via a mask that goes over your nose or nose and mouth to blow air in and out and help take over some of that work of breathing, can make a big difference, and actually in many studies has been shown to not only improve quality of life and symptoms, but to extend life. So that's the Trilogy. Trilogy is one of those two agents I showed you that is a LAMA inhaled corticosteroid. So two bronchodilators and a steroid together. There are two available agents that do that in the United States. And in regard to that, if I hear that someone's saying, I've used Trilogy and it's quote unquote not working, the question is why? And of course, the issue I think is possibly it's not working because we're treating the wrong thing, but that's probably not the case. Or it's just not working as well as we would like it to be working. And unfortunately, the medications for COPD don't cure COPD. They don't put someone with COPD up to a point where they have normal lung function. And so the abnormalities that exist can be fixed. The purpose of medication, as we talked about, is to decrease symptoms. Notice I didn't say, I wish I could say, but I didn't say eliminate symptoms. It's to improve quality of life, not necessarily return you to the quality of life you might have if you didn't have any lung disease. And so that's perhaps part of the reality also.
Great, thank you. I had another question that came in asking about the FeNO test. Is that a test that you use to diagnose COPD, or when does that get used?
So FeNO, or fractional excretion of nitric oxide, is a test that is not routinely, first of all, it's not routinely used in anything based on most standard guidelines, but we do use this for asthma. Nitric oxide is a potent vasodilator and bronchodilator, meaning it causes blood vessels and airways to open up. And it's something that the airways, the cells that line the airways, makes some all the time, but it makes more when there's lots of inflammation. So in the setting of, say, asthma, which is primarily an inflammatory disease, where it's not optimally controlled, we can see a high level of nitric oxide when someone exhales, or their FeNO. Their FeNO is high. And one can use that to sometimes confirm that there's inflammation and to kind of help guide anti-inflammatory inhaled therapy like inhaled steroids. There's reason to question whether using that in COPD, chronic bronchitis, might help as well, but that's not part of any current guidelines of therapy.
Thank you. My last question is, can you maintain any kind of physical exercise with COPD? And how can you stay active and healthy if you're living with COPD?
Absolutely. That's a terrific question. And the answer is, first of all, absolutely, you should remain active. I think I've kind of addressed that a few times already. Again, doing nothing gets you really good at doing nothing, but really impairs most everything else in your life. Of course, and I want to acknowledge that there are some people who are at such a point with such severe disease that, doing almost anything can be quite difficult. I will tell you, just as a point of reference, probably 20 years ago when we were doing, nationally, there was a big study looking at that surgery I talked about, that lung volume reduction surgery, where you remove parts of both lungs, the tops of the lungs, in patients with bad emphysema in certain patients. The way to get into that study, it required that someone be able to complete a pulmonary rehab program and that they're able to walk for 20 minutes. And so I had so many patients at that time who told me they couldn't walk 10 feet and they would sit down after 10 feet and they would truly look like they were going to fall over after 10 feet. But they really, really wanted the surgery. And so they were really motivated to do pulmonary rehab. And so they went through pulmonary rehab, and guess what? After 5 or 6 weeks, they were walking on a treadmill for 20 minutes. Their quality of life was remarkably better. And guess what? At that point, they said, I don't want surgery. I feel so much better. And they were entirely appropriate, because it turned out that with very rare exceptions, that surgery isn't for most people. There are very few times where it's worthwhile. But so the bottom line is, I think often people with COPD admittedly have a hard time breathing, lots of symptoms, but they often underappreciate the potential they have for improvement with exercise. And again, you can't just say, okay, I remember when I was 20, I used to go out and run 5 miles, so I'm going to go try to do that now. You need to build up. And pulmonary rehab programs, other exercise programs, silver sneakers programs, they can all, it's, graded, slow, how do you eat an elephant, right? That old saying, how do you eat an elephant? And the answer is one bite at a time, right? And that's what it takes.
That's great. I did have one last question that just came in. Do you look for lung function improvement data when choosing a treatment for COPD patients?
Yeah. The honest answer is no, but yes. So here's the thing. Of course, we're always delighted. The more things that get better, the happier we are. And when there's objective evidence for improvement, that's terrific. But it turns out that clinically significant improvement in symptoms and clinically significant improvement in function, walking distance, quality of life, ability to do things, doesn't necessarily correlate completely with demonstrable changes on pulmonary function testing. So, every piece of information is important, and integrating that into, decisions is always important. You don't want to ignore things, but you don't want to, you rarely want to use any one thing as a stop sign.
Okay, thank you. I am so thrilled that you were here with us today. I do want to put up the phone number for anyone who may be interested in TMC Pulmonary Associates. The number is 520-318-1114. So please give them a call if you've got information. I'm going to wrap up with our online audience, Dr. Aronson, and then turn it over to in-person.
Questions? Can we
Yes,
do that?
you get to continue on. So thank you.
Oh, thank you. Okay.
Thanks so much for being here today. We look forward to seeing you again next week. Our next class is going to be prescriptions and pitfalls, how medications impact fall risk, all part of our Fall Prevention Month with Dr. Catherine Dowell. She'll be here on Tuesday, September 17th at 10 a.m. If you're interested in that class, please give us a call. The phone number is 520-324-1960. Hope you have a great weekend, and we'll see you next week. Thank you.